lecture from Vienna to Moscow. It's a great opportunity for me to deliver ideas and do a knowledge transfer on hemostatic agents. This is my declaration of potential conflicts of interest and list, but this lecture now is really for academic purposes only. I will talk about physiology because this is our polar star also for procoagulant management, and I will give you some comments on drugs, on agents that are able to stop bleeding, and of course I will always come back to the ESA bleeding guidelines, European Society of Anesthesiology guidelines. So please may I remind you to our physiology of hemostasis. We believe in that cell-based model of hemostasis currently, which is not divided into a primary and secondary hemostasis, ankle, and in extrinsic and intrinsic cascade, but rather on the cell surface of platelets predominantly, hemostasis takes place and is separated into initiation, amplification, and propagation phase. And I will briefly summarize and describe what's going on and what we currently understand what physiology of hemostasis means. If this scheme resembles a vascular space with a lesion here in the middle of this upper part of the scheme, then the vascular lesion is the kick-off event for all further coagulation processes. It comes to the exposure of subendothelial matrix. And there, at the site of lesion, primary hemostasis with the platelet starts. There is adhesion to the subendothelium, which means the binding of platelets to the lesion area, and this is mediated predominantly by a von Willebrand factor. And von Willebrand factor is a large molecule, probably the largest, one of the largest molecules we have in our body, produced in endothelial cells and platelets and the subendothelium itself. And it also works for binding and adhesion at sites of high shear stress in the vasculature. Platelet reactivity is multifold, and it comprises not only the binding, the adhesion, but also the activation, which is pharmacologically or physiologically done by collagen and thrombin, and platelets change their shape. In my scheme, the large molecule Willebrand factor is that colored binding region here, and the platelets are the round gray things. And upon shift change, they change and become like this, with their long pseudopodia and their activation state. In reality, it may look like this: change from a discrete form to a form of activated platelets with these pseudopodia. Another platelet reactivity aspect is that they can secrete content, and they have dense granula with specific contents, and they have alpha granula containing also fibrinogen from Willebrand factor and fibronectin. A platelet reactivity aspect we can indeed measure in specific modes of monitoring devices is aggregation, binding of activated platelets to each other. And what is necessary for this is a receptor of glycoprotein to be conveyed, and the ligand in between of these platelets is fibrinogen. Platelet reactivity is also, and probably this is the most important functionality of platelets, the procoagulant activity. This means that on the surface of the activated platelets, exposing negatively charged surfaces, there the coagulation cascade takes place. So this platelet reactivity, procoagulant activity, is the prerequisite that bleeding and coagulation, not bleeding stops and coagulation occurs. On the surfaces of the activated platelets, cascades take place. And in the initiation phase of these cascades, the initial factor of importance is tissue factor TF, which binds to factor 7 and converts it thereby to activated factor 7A. And this combination of tissue factor together with 7A activates finally 10 to 10A. So this is the main aspect of the initiation phase. In the end of this phase, small amounts of thrombin, which is 2A, are produced by 10A. So this is the initiation, which is important in our physiology. The next step is amplification. In the Yosser loop, it's called Yosser loop, the factor complex of tissue factor and 7A also activates 9 to 9A. And another very important aspect of amplification is the activation of 5 and 8 by thrombin, by the little bit of thrombin built in the initiation phase. With this process, the system is primed and the propagation phase takes place, meaning that the formed factor 8A together with 9A in this Tranexamic complex produce a complex called prothrombinase complex consisting of 5A and 10A, and this is so strong and activating, potentiating the activity of factor 10A, so that not only a little bit of thrombin is produced, a lot. It's called thrombin burst, because so much thrombin is produced. And this is enough in the propagation phase to trigger the formation of fibrin. Fibrin needs to be polymerizated, which means that by putting fibrin dimers together to polymers and cross-linking it by factor 13A, this is a stable, robust clot. Fibrinolysis is the step required to degrade clot later on, and it is dependent on the transformation of plasminogen to plasmin by tissue plasminogen activator, TPA, so the fibrin net can be degraded to fibrinopeptides. Fibrinolysis, a very important physiological step. This is my scheme for all the further explanations how our hemostatic agents work. The lesion is first primary hemostasis with the activation of platelets and their reactivity takes place. Then, after a specific short time interval, thrombin is generated. First a little bit, then with all the amplification processes, a lot. Thrombin burst leading to fibrin, which finally is cross-linked and polymerizated so that a clot formation takes place. The clot gets thicker and the quality higher. Finally, lysis occurs. And this scheme is a simplification, of course, but suited for anesthesiological purposes, and our task is to correct the bleeding, so to have a scheme of hemostasis in mind is important. It looks quite similar. It starts with primary hemostasis, the clot grows, thrombin is generated, and then we have a thick clot. Coagulation visualized by these plastic hemostatic assays. You will hear later during the course today about ROTEM and TEG, and these tests really allow us to visualize coagulation. So for hemostatic therapy, you need several aspects to be catched and considered. The big five requirements for stop bleeding are: the patient needs a matrix, platelets, subendothelium, coagulation factors, predominantly for the amplification phase. The patient needs substrate, and you as a doctor need to take care that enough substrate is on board while there is a bleeding risk, meaning fibrinogen. The milieu is important, such as temperature, pH and calcium levels, and the vessels are important because vasoconstriction or external pressure may of course induce bleeding stop. So our therapeutic options are now shown in the scheme I prepared earlier on. We have plasma or cryoprecipitate as a therapeutic option. We have fibrinogen concentrate. We have DDAP, desmopressin and proliferant factor, PCC, recombinant factor 7A, factors 8 and 9, factor 13, and tranexamic acid. And the position of these therapeutic options in this scheme reflect their mode of action, where they act in the coagulation cascade. If our patient is hypocoagulable, hypocoagulability means that the clot strength goes down. So in a viscoelastic trait, you will see that the clot strength, the amplitude is getting lower. What can we do? We can give fibrinogen as a concentrate, for example. And in these letters, italic letters, you have names of products commercially available in Austria, but also globally. My comment for fibrinogen concentration to give you now a few aspects on the therapeutic agenda. Fibrinogen substitution is important because fibrinogen loss is an early and very frequent cause of bleeding. So if we manage this, we have done a good job already. We have robust scientific evidence for supporting fibrinogen substitution in hypocoagulability, and we have also specific triggers, but for various fields in medicine, peripartum, hemorrhage, cardiac surgery, neurosurgery, we need to define trigger values in further studies. Mostly, the trigger for administering fibrinogen is a FIBTEM. You will learn about these tests later on. A FIBTEM 85 is less than 5 to 12 millimeters, depending on the scientific field or the clinical field. If fibrinogen is measured by level measurements, Klaus measurements, then a cutoff of 150 milligram per deciliter can be applied. In this slide, you see those calculations considering the target value of the FIBTEM or the fibrinogen level and the actual level of the bleeding patient. We always correct fibrinogen only if there is bleeding, so this is a prerequisite. Side effects, they are rare. Venous thromboembolism is not frequently seen, is rarely seen, probably because fibrinogen is antithrombin 1. Fibrinogen concentrate is also used in some occasions to push platelet functionality. If there is a defective platelet function, fibrinogen concentrate may help because it is the ligand between activated platelets for their aggregation. For this indication, however, the evidence is not robust yet. If you do not take a viscoelastic hemostatic assay, but rather do a microscopic testing, you will see, starting out on the left side with a strong clot, diluting it massively up to 70% with a colloid, the clot gets weaker. And if you add fibrinogen again, the clot gets stronger. strong again, and it is comparable to the picture of the initial situation. So fibrinogen concentrate works. I would like to propose to announce a day during the year as the Fibrinogen Day, but until now nobody really approved my proposal. But at least we prepared a small book on fibrinogen replacement European acquired therapeutic. If one of you is interested, please tell Anastasia that I should send you my book with warm regards. What you can have right now is download of our guidelines from the European Society of Anesthesiology on the management of severe perioperative bleeding. And in these guidelines, of course, the management and the repertoire of hemostatic agents is included. So we do give ideas and recommendations what to give when. If there is hypofibrinogenemia, then we do recommend fibrinogen concentrate. We give dose recommendations, trigger values, and we give alternatives if it is not available. For example, the use of cryoprecipitate. We recommend treatment of hypofibrinogenemia in bleeding patients. Bleeding as a prerequisite of any action. So is fibrinogen substitution relevant intraoperatively according to the ASA guidelines and the systematic review behind? Yes, fibrinogen substitution is relevant intraoperatively. Preoperatively? No. We have only a few studies in cardiac surgery. Preemptive administration of fibrinogen was not helpful and is not recommended. Is viscoelastic hemostatic assay sensitive to hypofibrinogenemia? Yes, it is. This is why we recommend the use of rotin and TEG. Another possibility aside from hypofibrinogenemia, for having a low clot quality, meaning hypocoagulability, is that factor 13 is missing. This factor is required for cross-linking and making the clot strong. Comment? This is a late cause of bleeding, a late pathomechanism of bleeding, probably not before the transfer of the patient from the OR to the ICU. So the scientific evidence is still weak, but we do have some data also in neurosurgical fields done here in Austria. Trigger value, factor 13 activity below 60% if in most centers the trigger for administering factor 13 concentrate. Side effects are rare. And in the ASA guideline, we do recommend that at least at activity level of 30%, we should suggest the administration of the concentrate. And for your field, because I think you are most interested in neurosurgical and aspects in this area, I picked out another recommendation or statement in the ASA guidelines saying that low platelet counts, low plasma fibrinogen concentration, and low factor 13 levels are predictive of bleeding complications in intracranial hemorrhage, intracranial surgery, and major spine surgery. So this may be of relevance to you, dear colleagues. Hyperfibrinolysis, the problem is at this side of the scheme. What can we do in terms of hemostatic intervention? We can give tranexamic acid. Comments. This is an early and very frequent cause of bleeding. If we give tranexamic acid and we block the building of plasmin with a half-life of about 2 hours, we have robust evidence to support our actions. Trigger values? Well, mostly it is given in elective surgery as a prophylaxis. We start giving tranexamic acid after induction of anesthesia or spinal anesthesia. However, if we see in a viscoelastic hemostatic assay, such as in the XIII, a tapering trace, a typical shape of the curve,
with a high lysis index, then we give it, as well in terms of a therapeutic approach. The dose recommendations are not quite clear. Bolus plus continuous infusion, bolus plus bolus, only bolus, at which dose, ceiling effect or not. There are many recipes published, but this dose of about 10 to 55 milligrams per kilogram may work. Side effects are rare. Seizures should be considered specifically in smaller patients. Tranexamic acid is one of our heroes in hemostatic management. The routes of administration are multifold. You can rinse orally in patients with teeth bleeding and inherited bleeding disorders, for example. You can prescribe it as a tablet. Swallow the content of the ampule as fluid. You can do a local infiltration, for example, in the replaced knee or hip joint, and you can of course give the intravenous. So many administration routes except for transdermal. In the ESA guideline, it has a strong recommendation: tranexamic acid should be given. 1B. If the problem is on another side, platelet dysfunction, what can we do here to stop bleeding, to improve coagulability? Desmopressin is a weak drug, but it's an option. It should be considered. What is the action of desmopressin? It secretes from the endothelium Fibrinogen factor 8, and tissue plasminogen activator. This is the reason why some anesthesiologists and centers recommend combination of desmopressin with tranexamic acid. It squeezes out of the endothelium also nitrous oxide, thereby promoting vasodilation and probably decrease in blood pressure. Trigger values are not so clear, but if platelet function assays like the platelet function analyzer, PFA, is prolonged, or for Fibrinogen factor antigen is decreased, according to the cutoff values in your lab, you should consider desmopressin use. Hypotension is a potential side effect, and the antidiuretic effect may lead to fluid retention. The classical dose is 0.3 microgram per kilogram, given as a bolus in 30 minutes. The ESA guideline tells us to suggest DDAVP under specific conditions such as Fibrinogen syndrome. Another option to correct platelet dysfunction is the administration of platelet concentrates, simply to add fresh functioning platelets. But most people do not know the functionality and the reactivity of the transfused platelets. And if you measure, for example, applicability, it may be poor. Side effects: platelet concentrate may induce sepsis, infections, various transfusion-associated complications. Since it is stored at room temperature, it has a high risk of pathogen transfer. Hypoactivation means that thrombin generation is slowed down and it takes too long to produce a clot. Our hemostatic action would be to give PCC-concentrate, prothrombin complex concentrate. We give it and the INR is prolonged, or in our viscoelastic hemostatic assays, if the XCT is longer than 80 seconds or 90 seconds. This is the cutoff value in most of our algorithms. We have good and strong evidence for giving PCC in vitamin K antagonists induced bleeding in combination given with vitamin K. In other scenarios, trigger values need to be defined. The dose rather go low, 25 or 20 units per kilogram, because it is thrombogenic. If you push thrombin generation, you may push the risk for these thromboembolic events. This is the wording in the ESA guidelines on the use of PCC in vitamin K antagonist-induced bleeding. Give it 1B recommendation. Another thing why hypoactivation can be reduced is that very strong promoter of thrombin generation is missing, and this can be overcome by the administration of recombinant factor 7A. In previous decades, it was quite popular to stop bleeding by the administration of recombinant factor 7A, but the trigger is not clear. Currently, we give it only if conventional therapy fails. At this dose recommendation, always considering the fact that it is off-label use and it is expensive and it is very thrombogenic. So in the ESA guideline, finally, we say fatal thrombosis, be aware and don't use it as a prophylactic need 1B. It is off-label and we should rather promote all prerequisites for the functionality of recombinant factor 7A before giving it itself. And often, after correcting fibrinogen levels and after correcting acidosis and platelet numbers, no recombinant factor 7A is necessary and important. FFPE, fresh frozen plasma, or any other plasma, is also considered as a pro-hemostatic agent, but in the perioperative and trauma scenario, it has not been proven as efficacious. To the contrary, it was not. Trigger values have not been defined, even though it is a tradition to give plasma to bleeding patients. The only rational and logical aspect to choose plasma would be in severe massive bleeding, where we have the idea that factor 5 and factor 11 could be deficient. We have no concentrate, no factor concentrate to correct these deficiencies. The dose is high if you have to work for coagulation factor substitution with plasma. You need up to 30 milliliters per kilogram body weight of the patient, which is a lot. Complication list is long. All transfusion-related problems may be there, and the most important one may be immunomodulation, leading to middle and long-term morbidity. So in the ESA guideline, we recommend against indiscriminate use, and other sources of coagulation factor should be given first, concentrates or cryoprecipitate. 1B. In the patient blood management bundle concept, consisting of various aspects of interventions, goal-directed therapy to correct coagulopathy is an important aspect. Procoagulants given when needed, and I try to give you a concept when to give what. When to give what means goal-directed our hemostatic agents administration, and this is also cost-effective. We have a course in patient blood management where you can discuss all these hemostatic interventions in much more detail, and where you also learn that surgical bleeding cannot be stopped by hemostatic agents, but rather only by the surgical skills. And this is the list of surgical bleed management. Algorithms are recommended highly, and specifically, viscoelastic hemostatic assays should be implemented into intervention algorithms. This is an example of our hospital internal SAP rapid bleeding control, where of course viscoelastic hemostatic assay is available. I'm not sure whether I should go into further detail the management of von Willebrand syndrome and hemophilia. The only thing I would, because I'm running out of time, I think, the only thing I would like to show you is this here, new hemostatic agents and their perioperative consideration we have recently published in the Journal of Pharmaceutical Design. And there are also new drugs such as recombinant biligraph factor or others, new drugs are described. So with this, dear colleagues, I would like to come to a conclusion for this first lecture. We have a big repertoire of hemostatic agents. This is large and increasing. We have various agents to correct hypocoagulability, hypoactivation, platelet dysfunction, and hyperfibrinolysis. Questions?